Good morning. Thank you, Paul, and thank you to Medacta. So I've been asked to talk about activity in sports after hip replacement, facts versus myths, what our patients should be doing, or probably more importantly, should not be doing. These are my disclosures, which are not relevant. So traditionally, these are the activities or sports that we allow and even encourage our patients to participate in after hip replacement. And subsequently, these are the activities and sports that we discourage them from participating in the high contact or high impact contact sports. However, the psyche of our hip patients are changing over the years. They're younger, they're more demanding, they're more active, and they have higher expectations. And where is the greatest percentage growth in our hip volume? It's the age group 45 to 54. And now over 40% of our hip patients are under the age of 65 at the time of surgery. As surgeons, I think it's important that we encourage our patients to remain physically active. There are general health benefits, mental health benefits, cardiovascular benefits, and it also improves bone quality, which is important for prosthesis fixation, and has been shown in the literature to reduce the incidence of early loosening. But how much is too much? Wear is dependent on a few things. The number of cycles or steps that we take, and this has a linear relationship to wear. The load, which is a function of body weight and activity, and this has an exponential relationship to wear. And then finally, material properties of the bearing, surface roughness, which has an exponential relationship to wear. So what do you tell a 46-year-old patient that comes to your office and wants a hip replacement and also wants to return to marathon running? What he didn't tell me was after his hip replacement, he went back and did a half a marathon at 10 weeks. And then did a full marathon at 8 months, and he placed 25th out of 431, and he qualified for the Boston Marathon next year, which he has every intention of doing. I told him he was crazy. Of course, he's doing well. This is early follow-up, just over a year. I just saw him back. He was done in an ambulatory surgery center, anterior approach, 32 millimeter ceramic head against high cross poly. A couple of other patients here, if we can cue that first video. Oh, there we go. Not as exciting as Fred's video, but this is a lady who's a fitness model and showed me that she wanted to be able to do this after surgery. I did simultaneous bilateral anterior approach hips on her, and that's her at 16 weeks. And then the video on the second screen is one of our anesthesiologists, telemark skiing at 12 weeks. No flips, but. So sports are important for many of our patients. For some, high-impact sports are important, and denying them of this could mean a loss of lust for life. And the goals of our patients don't always match ours. We're concerned with x-rays and survival of the implant. Patients want a pain-free hip that functions well, and oftentimes they're less concerned about a revision down the road. As surgeons, we do tend to be conservative in our advice. We feel responsible to our patients and to the implant. There's some medical legal concerns. As surgeons, we're scientists. We want to base our recommendations on science. The literature in this arena is sparse. There's no prospective randomized controlled trials. Most of the literature is based on personal preferences and survey results. Return to sport is common after hip replacement. There's a number of studies that document this. This first one shows increased participation in low-impact activities after hip replacement. Walking, cycling, swimming, and cross-country skiing all go up dramatically. The next one shows that 36% of patients maintain their sports immediately after hip replacement, and that goes up to 50% after 5 years. Even return to higher impact activities is common, probably more common than we think. This first study shows a high percentage of patients going back to jogging after their surgery. Short-term follow-up at 5 years, no pain and no loosening. The next study shows return to judo, non-competitive judo, 80% returned within 4 months. 9-year follow-up, a little longer, we're starting to see some issues, 2 revisions due to loosening. So what kind of forces and loads do our hip replacements see with sports? Obviously, the loads go up, and there's different ways to measure this. The most accurate is an in vivo hip prosthesis, where we get direct measurement and telemetric data. Bergman has published a number of times on this. And obviously, the body weight goes up significantly with different sports, and this shows some of the common ones. Cycling, as we often recommend to our patients, is a very good one, less than walking, all the way up to alpine skiing with large moguls. So the loads go up in the hip after a hip replacement, but what are our main concerns with patients returning to sport? Trauma, namely dislocation and fracture, and then also wear, probably more importantly. Dislocation, it turns out, is a relative non-issue. It is not more frequent in the active population. Dislocation risk is better predicted through a couple of other things, such as head size. With increasing head size, that dislocation rate goes down, and the risk of revision for dislocation does not justify using heads greater than 36 millimeters, where we're going to start to get into volumetric wear, especially on our young active patients. Our younger patients have a lower risk of dislocation, better musculature, better abductors, which is important for hip stability. Periprosthetic fracture, this is rare. It is increased in females, older patients, and implants that have been in for a long time. But there's no evidence for increased periprosthetic fracture risk in the presence of a hip replacement. But obviously the sequelae, if there's a hip replacement in place, are more severe. I think it's prudent to avoid contact sports and avoid learning technically demanding high-impact sports after a hip replacement. And there's some bone density work that shows we should probably be waiting up to 6 months before we're allowing our patients to go back to high-impact sports. Wear is our biggest concern. Activity leads to wear, leads to osteolysis, which leads to aseptic implant loosening, which is a leading cause of total joint failure. An interesting little fact on the bottom, 500,000 submicron sized polyethylene particles are released every step we take. Think about that. So there is literature showing the effects of sport on wear. The first is a retrospective study, minimum follow-up 10 years, 70 high-impact patients versus 140 low-impact patients. Hip scores are better in the more active population, but polyethylene wear is higher, revision rate is higher, 20% versus 6%, and the 15-year survival rate is lower at 80% versus 93%. Most of the studies looking at this show the harmful effects of sports generally go undetected until around 10 years. So some of the early follow-up studies may not show a difference. So repetitive high contact forces do shorten implant survival. High poly wear leads to more osteolysis, leads to a higher revision rate, and the 15-year survival rate in highly active patients is lower. Keep in mind these are with older implants that are now 20 years old, so this may change with our newer implants. Over time, the literature shows surgeons are becoming more lenient in allowing our patients to go back to sports. This is probably reflected by our more confidence in our approaches, better bearing surfaces, high-cross polyethylene, as we've heard about. Patient expectations are higher, and our patients are not necessarily compliant, as we've seen with my patient. The literature shows high-volume surgeons are more liberal in their advice, and surgeons tend to be more liberal with hip replacements than knee replacements. Our societies, AUKUS and Hip Society, do have recommendations. These are based on survey results, not necessarily science. The ones in red are the ones we discourage our patients from participating in. These are our high-impact and contact sports. And then our same societies have recommendations in terms of time to return, typically 3 to 6 months. And that fits with the science. In summary, so the goal of hip replacement, reduce pain, enhance activity and function. Our primary concern is wear. Dislocation and fracture risk is low. I think it's important to know from our patients if they're going to be doing something for exercise regularly or for recreation. If it's for exercise, tell them to do something low impact, and 95% of our colleagues impose no limits on low impact activity. For recreation, where it's more periodic, I think higher impact activities are okay. We do need better studies and more long-term follow-up, especially on our newer modern implants, high-cross polyethylene, ceramic on ceramic. Wait 3 to 6 months to return to high-impact sports. These are all recommendations. We need to fully inform our patients and let them make the decision. So back to my patient, our 46-year-old guy who wants to do the Boston Marathon next year. What do I tell him? Enjoy life. Check it off the bucket list, or you're crazy. You're going to ruin your hip replacement. This is what I told him. Buy a bike. Thank you.